Yes, it's clear.
Dr. Mustafa,
yes, I'm here. Yeah. Okay, we'll start.
Yes, please.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It's my pleasure to be with you today in the second day of our stroke webinar. Yesterday, we worked with Dr. Majid Bakir, Dr. Saeed Zahrani, and Professor Hirmus. They discussed the management of a patient with acute stroke in the emergency room, and they discussed the importance of stroke unit and the importance of stroke prevention. Today, we are happy to have our speaker, Dr. Naif Al-Harbi, is a stroke neurologist and a neurointerventionist, King Fahd General Hospital, Jeddah. And after that, Dr. Muhammad Al-Wadi, he's a stroke neurologist also and a neurointerventionist, King Fahd General Hospital, Jeddah. And we'll have also Professor Ashfaq Shoaibi. He will talk about understanding of the importance of the time in management of acute stroke. He's a director of stroke program, Department of Medicine, University of Alberta, Canada. I would like to thank our organizing committee for this successful organization of the symposium. And I want to have this chance to thank our team and Surgeon Hospital Jeddah, Neurology Department, and the Stroke Unit for achieving GCI as a primary stroke center. Now we'll start with our guest speaker. Then after each one, we'll have 5 to 10 minutes discussion. Dr. Wadi, he has patients, so maybe he will be late. He will be the late, and maybe he will be the last one if he cannot join us now. Now we'll start with Dr. Naif Al-Harbi. He will talk about neuroimaging in stroke. Let's start with Dr. Naif.
Assalamu alaikum. Hello, everyone. Thank you, Dr. Mustafa, for inviting me. And today we'll talk about the neuroimaging and the importance of the neuroimaging in acute ischemic stroke. I have nothing to disclose. The outline we'll talk just brief an overview about the images, and then we'll talk about the CT brain, the non-contrast CT brain with the early signs of acute ischemic stroke. And then we'll talk about the aspect score and the importance of the aspect score. And then we'll talk about the CT angiogram to decide about the location of the stroke and the collateral score. Then we'll talk about the perfusion studies, including CT perfusion or MR perfusion. Then what are the current evidence or the guidelines for the neuroimaging in the acute ischemic stroke? So what are the importance factor of imaging or neuroimaging in acute ischemic stroke? The first important thing is to rule out hemorrhage and then to rule out stroke mimics. And presence of early ischemic changes to detect the site of the occlusion and to measure the collateral score, which is a poor collateral, intermediate, or good collateral. Then, is there any salvageable tissue? For patient selection, is the patient candidate for IVTBA or mechanical thrombectomy, or both, or none of them? So we'll start with non-contrast CT brain. The advantage of non-contrast CT brain is fast and widespread access in the hyperacute phase to exclude or confirm hemorrhage, and also to exclude or confirm the stroke mimics. Immediate CT scan for all patients with suspected stroke is the most cost-effective strategy till now. The role of CT in early stroke. CT brain typically cannot diagnose the acute stroke, especially in the less than 3 hours time frame. But what are the early signs of infarction or the early ischemic changes that we are seeing in the non-contrast CT brain, especially if the patient present in the first 3 hours? First sign is the hypoattenuation involving the 1/3 or more of the middle cerebral artery territory. Also, there is the loss of gray-white matter differentiation in the basal ganglia, obscuration of the lentiform nucleus, or loss of insular ribble or insular ribble sign, or obscuration of the cerebral fissure, cortical sulcal effacement, focal parenchymal hypoattenuation or swelling, also the hyper attenuation of the large vessel, like the hyperdense MCA in the M1 segment, or the dot sign in the distal branches of the middle cerebral arteries. As you can see here in this non-contrast axial cut CT brain with patient with right MCA occlusion who present in the first few hours shows there is hypoattenuation of the right insula in the white arrow, which is the insular ribbon sign. And this is another patient with a left MCA stroke. There is a loss of normal gray-white matter density in the left insula, left cortical gyri, and the left basal ganglia. That become more prominent at the narrow window width. We'll talk about the stroke window or the window width in this presentation. But you can see the difference if you change it to the narrow width or the stroke window width, like in this patient. So the earliest chemical change, the hyperdense MCA, sign first reported by Cox and his colleague in the setting of the acute ischemic stroke. The principle behind that was the attenuation rises from 40 Hounsfield unit in the flowing blood to approximately 80 Hounsfield unit of the for clotted blood. But be aware of the pseudo-hyperdense MCA sign, which we'll talk about. The absolute attenuation of more than 43 Hounsfield unit. The middle cerebral artery ratio of affected slash to normal is more than 1.2. If you are in doubt, the CT angiogram or MRA to assist will assist you in promote the diagnosis of the doubtful cases. As you can see in this picture, this patient has a hyperdense sign in the left middle cerebral artery, and the absolute attenuation value of the left MCA was 36 Hounsfield unit, and of the right MCA was 35 Hounsfield unit. So it's kind of pseudo hyperdense vessels. And in the picture, the right picture, the MRA showed patent MCA in the left M1. So what are the differential diagnoses of the hyperdense vessel sign, or what are the causes of the pseudo hyperdense vessel? We have intraluminal causes, we have vessel wall causes, and we have also pseudo hyperdensity. The intraluminal causes like thrombosed vessels, hematocrit more than 60%, or the contrast dye or increased serum density. Vessel walls like calcification, atherosclerosis, hyperlipidemia, or lipohydrosis in the hypertension and diabetic patient. The pseudo hyperdensity like volume averaging, or if there is adjacent tumor infection or contusion, that might give you a false expression if the patient has the hyperdense MCA. And in this picture, you can see the dot sign in the M2 branches. The CT shows the hyperdensity of the M2 branch in the Silver Fisher MCA dot sign, which also appears plumber than the contrast at the contralateral side of the black arrow. The repeated scan 24-hour in the same patient shows the infarcted area, confirming the infarction at the same location. So after the non-contrast CT brain, the early changes in the non-contrast CT brain, we have to measure the aspect score. Aspect, which is the Alberta Stroke Program early CT scan score, the MCA territory 10 regions of interest, which are weighted based on functional importance. The aspect is a weighted volumetric scale. So it's out of 10 points. We have subganglionic level or supraganglionic level or basal ganglion level. The subganglionic level from M1 for frontal operculum, M2 for anterior temporal lobe, M3 for posterior temporal lobe, M4 for the anterior MCA, M5 for lateral MCA, M6 for posterior MCA. In the basal ganglia, we have the caudate, lentifor, insula, and internal capsule. So the total aspect score is out of 10. If the patient aspect score is less than 6, there is high risk of hemorrhagic transformation, and we have to question ourselves: is this patient going to benefit from the acute treatment or not? Pitfalls of the aspect score: patient motion may affect interpretation of the aspect. The changes are the best identified at the scan window. If it is the regular window or stroke window, avoid scoring aspect score at the standard window level. Presence of atrophy arteriosus and old infarct. Carefully evaluate and supplement aspect with collateral and CT angiograph source images. Also, the watershed infarction sometimes might, it's difficult to calculate the aspect score. And the aspect score here for MCA, for the middle cerebral artery branches. Is there aspect score for another territory? Yes. The posterior circulation aspect score, we'll talk about it. How to enhance the sensitivity or change the width, the window from the regular window to stroke window, window width and central level adjustment, window width range of CT number that will be displayed with different shades of gray, ranging from black to white. So the scan window is important. As you can see in this patient who presented with left MCA stroke, and the regular scan window was 80 width with 30 central level. So the aspect score is only 8. There's loss of the left insula and the left lentiform nucleus. Once you change the window to the stroke window, the window 50 by 30, you can see the aspect score is almost 4. There is loss of left insula, lentiform, head of caudate, M2, 4, and 5. So it's important once you, when you are measuring the aspect score, to see the narrow window as well as the stroke window. This is the posterior circulation aspect score. Also a score from 10 point, 2 points for the bones, 2 points for the cerebellum, 2 points for the midbrain, and 2 points for both thalami, and 2 points for the occipital. But it's not highly or used, commonly used. Key points: CT hypodensity in the first 6 hours period is highly specific for irreversible ischemic brain damage. On the other hand, there is controversies about prognostic value in early CT sign of cerebral ischemia and the patients with global outcome after the stroke. Sensitivity of the non-contrast CT brain, 31% in the first 3 hours, 40 to 60% in the first 6 hours. The low rate occurs because of the poor performance of the CT in detecting the small cortical infarct or the posterior circulation. What about the CT angiogram or the multi-phase CTA? What are the importance of the CT angiogram multi-phase CTA? The ideal, the CT angiogram to be done from the aortic arch to the vertex to check for the site of the occlusion. Is it a large vessel occlusion or small vessel? Is there tandem lesion? Is there internal carotid artery occlusion or dissection? Assess the road. If the patient is going for mechanical thrombectomy, the CT angiogram is important to see the type of aortic arch and the tortuosity to decide which materials or catheters you are going to use. Then to assess the collateral score, is it good, intermediate, or poor collateral? And also improved detection of early ischemic changes compared to non-contrast CT. So the CT angiogram diagnostic accuracy for intracranial atherosclerotic stenosis, sensitivity of 78 to 80% for detection of 70 to 99% and 100% for occluded segment. In contrast, the MRA has sensitivity 70 with possible prescriptive value of 65%. As you can see here in this picture, the normal brain become hyperdense because of the intravascular contrast. If you compare the picture on the left A and B, the infarcted brain will not change in density, making the infarcted more apparent. Obvious relative hypodensity in the left MCA and anterior cerebral artery distribution. Is there any evidence to check the aspect score in the CT angiogram? Actually, it will help you if you see the aspect score in the source images of the CT angiogram. The hypoattenuation of the CT angiogram source images is an indicator of reduced cerebral blood volume in the area of ischemia, and is not as time dependent as the ischemia in the non-contrast CT. Also, they found that the areas of hypoattenuation, the CTA source images correlate well with lesion in DWI, diffusion-based images in the MRI. As you can see here, early ischemic changes in the left basal ganglia and insula aspect score was 8. In the CT angiogram source images, there is extensive hypocontrast in the left hemisphere, and the aspect score was 3. And that was the follow-up CT thing. Also, there is another score called clot burden score, but also is not commonly used in the CT angiogram. It's a score of 10 indicates absence of visible occlusion in the CTA. A score of 0 indicates occlusion of all major anterior circulations artery. What about the multi-phase CTA? Is the CT angiogram with the 3 phases to check if the patient has a good collateral, intermediate, or poor collateral. If there is an early backfilling, like as you can see in this picture, the first row is a good collateral, and you can see the site of occlusion in the left M1, and the phase 1 shows the contrast filling in all the area, and the phase 2 and as you can see, once you are going to venous phase, I mean the backfilling in the first phase and near complete washout by the third phase, the collateral occupying more than 50% of the affected MCA. And if you look to the intermediate collaterals, also in the same patient, there is a delay in the second and third phase. But in the poor collateral, there is also a delay in the second and third phase of backfilling with very few vessels is only identified. So the CT angiogram is an ideal tool for rapid and accurate detection of intracranial stenosis or the site of the occlusion, if there is large occlusion or not, and also help to differentiate patients who will benefit from specific recanalization technique. What about the perfusion study, the CT perfusion or MR perfusion? Always remember, the perfusion studies are for hemodynamic state, not for the tissue fate. Core is the damaged vessels, penumbra is the salvageable tissue. In this patient with the left MCA, this is an example of the left MCA stroke. You can see in the picture number A, there is a hypertensive left M1, and the CT perfusion showed delay in the time to peak and also delay to mean transit time and time to drain. And also there is this reduced cerebral blood flow in the left MCA territory. There appears to be no changes in the map permeability and also the cerebral blood volume. Perfusion measurement derived from the CT perfusion acquisition and their usual finding for core and penumbra in acute stroke. The CT perfusion can differentiate potentially salvageable penumbra from likely the unsalvageable or the infarcted core. If the patient had a stroke, there is a focally increased time to peak and reduced cerebral blood flow combined with reduced cerebral blood volume, like in this table, and indicate irreversible damage. But if there is low cerebral blood flow with near normal or increased cerebral blood volume, is characteristic of salvageable penumbra, and the patient might be candidate for therapy, either endovascular thrombectomy or TBA. Based on the CT perfusion or MR perfusion, the late window trial, diffuse and down trial from 6 hour to 24 hour, they were published in 2017 or 18. And the inclusion criteria based on the perfusion for endovascular thrombectomy. Diffuse 3 from 6 to 16 hour and down from 6 to 24 hour. They include patients above 80 years old, MRS less than 2, NIH in diffuse 6 or more, and then down 10 or more. And there is large occlusion, either ICA or M1 or both, tandem occlusion. And the inclusion criteria for AVT in the mismatched definition, if the infarcted core less than 70 and the mismatched volume more than 50, and the ratio more than 1.8 is in diffuse, and in down if the NIH more than 10 and infarcted core is less than 30, or if the patient is younger than 80 and infarcted core between 31 to 51. So these are the criteria for inclusion criteria for AVT based on the perfusion study, either CT or MRI. What are the evidence or the guidelines for the neuroimaging? In the guideline, the American Heart Association and American Stroke Association guideline for early management of acute ischemic stroke in 2019, as you can see here, the aspect score, it is 6 or more, is the class 1A evidence. If the patient who presents with less than 6 hours. for mechanical thrombectomy. And if the patient presents from 6 to 24 hours, it's class 1, 6 to 16 hours based on diffusion down is class 1A, or from 16 to 24 hour class 2A evidence for mechanical thrombectomy. What about the multi-phase CTA? It was used in ESCAPE and ESCAPE in one trial. Both trials enrolled patients up to 12 hours. And they found that the multi-phase CTA helps in more patients to being eligible for ABT and more benefit. As you can see in this graph, the ABT eligible patient on the CT perfusion was the blue circle, and the green circle 202 patient eligibility of patient on multi-phase CTA. And you can see also in the adjusted probability of the clinical improvement, also the patient who underwent mechanical thrombectomy or treatment based on the multi-phase CTA eligible are more than the patient who underwent only CT perfusion. In conclusion, imaging is important for patient selection, not for patient exclusion. CT is the fastest modality. Advanced imaging to include, not to exclude patient. Avoid repeating images, and always remember time is money. Thank you.
Thank you so much, Dr. Naif Al-Harbi. This is very excellent presentation. I want to ask the audience if they have any question for Dr. Naif. Please, if you have any question, can you write it in the Q&A? Dr. Naif, I want to ask you also one question. So if the patient is coming after 6 hours, it is mandatory to do the CT perfusion, or we can depend on any other investigation like diffusion and flare MRI?
Yeah, the CT perfusion or MR perfusion, if the patient presents after 6 hours, actually, if you want to follow the guidelines, has to be done and with the rapid software. So after 6 hours, from 6 to 16 hours, based on diffuse or down, is a class 1A evidence. But also we can depend on the CT angiogram or the multi-phase CTA to check the collateral. If the patient has very good collateral and his aspect was good, as you know, it was in the ESCAPE, they used the CTA up to 12 hours, which was also a benefit. So not only the CT perfusion, also we can use the multi-phase CTA.
Okay, no more question for Dr. There is another question for Dr. Naif. Is CT angio mandatory in all stroke code case, even with low NIH status score, low which reflects that no long vessel occlusion?
Yes, all patients who will present with acute ischemic stroke, the CT angiogram is mandatory because not all the large vessel occlusion present with high NIH. Or vice versa. Not all the patient with low NIH means there is no large vessel occlusion. Sometimes some patient, it depends on their collateral. So low NIH doesn't exclude large vessel occlusion. So CT angiogram is mandatory.
What about the TIA and rapid recovery?
What about, sorry?
About the patient with TIA and rapid recovery.
Only the CT brain, it's important, but the CT angiogram, if the patient is clinically fine, came back to normal. It depends actually, is it high risk TIA or just only numbness, or there is no slurred speech, weakness, dense weakness? So it depends on the TIA. Is it high risk TIA or
not? What about the posterior circulation? Is the same like anterior circulation?
Because once when the patient presents with acute ischemic stroke, we don't know is it anterior or posterior circulation. So CTA, if it's done for all patients, we're going to see what is the site of the occlusion. Is it in the basilar, vert, or anterior circulation?
Okay, another question. If the patient has high INR more than 3, which is contraindicated to give TBA, can go for mechanical thrombectomy?
Yes, can go for mechanical thrombectomy if the patient has aspect score more than 6 or NIH more than 6, and he presented within the first 6 hours based on the CT angiogram. And from or there is the CT perfusion was done, shows there is a good penumbra based on the diffuse or down.
Any other question for Dr. Naif regarding neuroimaging in stroke? Okay, Dr. Naif. Okay. Okay.
Okay, thank you so much.
Okay, thank you, Dr. Naif.
Thank you.
I don't know if Dr. Muhammad Al-Wadi is available or not yet.
I don't think so. He's. I think maybe
He has his.
Yeah, so maybe the last one he will be ready.
Okay. Now we have Professor Ashfaq Shoaib. He's director of stroke program, Department of Medicine, University of Alberta, Canada. I think Professor is he's the first one. I think he's the first one in Alberta who introduced this ambulance stroke mobile stroke unit. We will speak today about understanding the importance of timing in management of acute stroke. We are ready to hear from you, Professor Shoaib.
Thank you. Assalamu alaikum. It's my pleasure to join you as a speaker. I'm hoping you can see my slides. The title is Understanding the Importance of Time.
We can see.
You can see the slides. Thank you. So that's my title. I have my conflict of interest. There are none for this presentation. My synopsis is the following. I will first start by talking about some very essentials of care. In other words, if you're a nurse or a physician, when you first see the patient in emergency, what are the important things to do? And I'll also talk a little bit about the importance of a stroke unit, which congratulations to some of you. I understand you had your JCI accreditation and you have stroke units. That's excellent. The main portion of my talk is broken down into 4 sections, and these relate to predominantly the outcomes with reperfusion success. My first part would be on the golden hour, which is where the stroke ambulance becomes very important. And I'll show you why treating in the first hour gives you very good results. We'll then talk about the standard of care for thrombolysis, which is approximately between 2 to 4.5 hours. And then both thrombectomies as well as TPA. I will not talk at great length about thrombectomy as there is a presentation. Hopefully we'll have the speaker back here. And then just one slide on that there are some rare patients in whom with good collaterals you can actually intervene more than 24 hours into their stroke also. I wish to thank Naif Al-Harbi, who did a great job and made my life easy, because his presentation on imaging is very useful and helps me in my presentation. So that's my synopsis. And I'll start off with the following preamble. It is important that the primary goal, whenever you see a patient in the emergency department, you have to think of a few things. The very first thing is this patient a candidate for reperfusion therapy? In other words, do they have an occlusion and do they have good tissue that you can preserve and reverse injury? And for that, imaging is really important. Equally essential in the emergency department, I'll show you some data for that, is that these patients are extremely unstable. And I'll show you evidence from Qatar that they should not stay in the emergency and you should move them out to the stroke unit as soon as possible, because that is where most of the complications start, the aspiration, pneumonia, etc. Today, I will not be talking about preventing recurrences because it's outside the scope of my presentation. This includes things like managing their hypertension, starting them on anticoagulants, etc. So my strategy for today is the following three. You will stabilize the patient and prevent complications. You're going to do your imaging, which is helpful both in confirming your diagnosis and really importantly, you want to rule out mimics. In our center here in Alberta, 1 in 2 patients, 48% of patients, where the emergency doctors ask us to see the patient, they actually are not strokes. They're mimics. They're conditions like inner ear disease, hypoglycemia, an acute infection, dizziness that's non-specific, etc. Right? So you want to make sure that your imaging is utilized not only to see if the tissue is healthy or not, but you also have to exclude the mimics because you don't treat mimics with TPA, right? And as you're doing that, your imaging is also important if you want to determine whether the patient is a candidate for thrombolysis or for a thrombectomy. And all of this is important and has to be done very quickly. So the first thing then is to prevent complications. Remember that these patients who come in, a third of them, at least a third of them, progress. So they come in with a mild stroke, and as you're watching them, their stroke gets more severe. And part of it is because they may not be getting enough oxygen, they may be hypoxemic, their blood pressure may be fluctuating, and they may have hyperthermia. This may be central, or if they aspirate, or if they have arrhythmias, etc. So if they aspirate, they become hypoxemic and they may become febrile, but usually that fever does not come soon, very soon. So the patient is unstable, they're at a high risk for complications, especially arrhythmias, they can have seizures, and they can also have definitely infections of multiple organs, the chest and the bladder being the common ones. So our advice is that you must move this patient out of the emergency into your stroke unit as soon as possible. Let me show you some data. We published this work from Qatar, where we looked at patients. Here is the numbers in red, those who were discharged out of the emergency to the stroke unit within 8 hours or less, and the number of patients who stayed for more than 8 hours. So the majority, 80% of the patients, unfortunately, did not leave the emergency in under 8 hours. So if you look at the rates of complications, there were 14% in those who left early. This is really important if there are nurses in the audience. You've got to move that patient out as soon as possible. And that number increases to almost 20% simply by the location where the patient is. So move them fast. So if you had a choice of, they've got 3 patients in the emergency, which ones to move faster? We even have, we have data for that also, and I'll show you in here. So this data, we published this a few years ago. This data is on mild strokes, NIHSS of less than or equal to 4, moderate stroke, NIHSS of between 5 and 15, and severe strokes. So in the emergency department, the risk of complications increases from 3% to 11% to as high as almost 40% simply on the severity of their stroke. These patients with severe stroke are at the highest risk for aspiration and other complications. So if your stroke ward is busy and you've had multiple admissions to the emergency and you have a choice, you can leave the mild stroke patients longer than the severe stroke patients. And this translates into outcomes. So I showed you in here less than 8 hours or more than 8 hours. So if you look at these patients at 90 days, which is right here, outcome at 90 days, you can see that those who stayed in the emergency department for less than 8 hours versus more than 8 hours, there was an absolute difference of more than 11% of those who made full to nearly full recovery. So this is modified Rankin scale of 0 to 2, which means the patient can be discharged home. So these numbers are very impressive. Again, my first point then, move them out of the emergency as soon as possible. Secondly, why is the stroke unit so important? So here's data. This is from Qatar again, was one of the first studies we did when I was there a few years ago, that if you compare, we published it in Stroke, if you compare the medical ward to the stroke ward, your complications decrease from almost 11% to 5%. These are your total complications. And most of this is driven by pneumonias, UTIs, and bed sores. So stroke ward, fewer complications. And if the complications are fewer, this is what happens. So your hospital administrators would love you for this, that in the medical ward, your length of stay, your mean length of stay is 14 days, and on the stroke ward, it decreases to 6 days. This is very impressive. And your hospital can certainly use those extra days those patients are, that you're saving them. And also the prognosis, if you see the patients who make a good outcome, so MRS of 0 to 2, that increases from 56% if you're on the medical ward to nearly 70.4% those who are on the stroke ward. So I'm trying to make a case that move them fast or move them into the stroke ward. And while this was published in 2015, we tracked these patients until I was there, so 15, 16, 17, 18, and you can see that compared to pre-stroke ward, that's pre-stroke ward, your numbers you can maintain, your patients with pneumonias in 16, 17, and 18, your risk of UTI, and look at the bed sores, they almost disappeared, right? This is the advantage of having a stroke ward. You have to keep these numbers, and you've got to have regular daily, weekly, and monthly census on whether you can meet these parameters or not. And why is that important is shown in here. This is from last year, that if you look at outcomes and you look at mortality, there's a difference of between 18% if you're not keeping track of your outcome parameters. You can decrease that from 18% to as low as 2.4% by simply tracking the things that I've shown you on the left side of the screen. Early rehab is very important, and you've got to monitor that. You go to image your patients, and the imaging is not just the brain. You want to make sure that they're not at risk for aspiration pneumonias, right? You also want to screen for arrhythmias in these patients. And you want to start your treatments as soon as possible. So antiplatelets within 48 hours. Those who are eligible for TPA, they must be treated as soon as possible, which is within less than an hour, and these patients must go to a stroke unit. So if you meet these parameters, if you're in the 90 to 100% in here, your mortality is 2.4%. But if you don't meet these parameters, or if you're not tracking them, you can see there's almost a 10-fold, a 9-fold increase in hospital mortality. So that was the first part of my presentation. Get them out of the emergency fast, put them in a stroke unit, and monitor what you're doing. It's not very difficult quality indicators. All right. The second part then is confirm your diagnosis and rule out mimics. And the way you do that is, once you do an examination, it should be very brief. Most stroke syndromes follow classic patterns. For example, if you have an occlusion in the left middle cerebral artery, you would expect the patient to have some degree of speech difficulties and right-sided weakness. They may also have eye deviation. The They may have a hemianopsy on the right side also. This should be very quick. These things should happen within 5 minutes, and this is what we train our residents and fellows to do. Glucose is important. Your INRs are very important. You make sure that they're not, the platelets are not low, and make sure that they don't have any electrolyte imbalance that could account for some symptoms that are coming from mimics as opposed to a real stroke. Imaging has been discussed, and I'll come back to that again when we look at the various windows of treatment. Sometimes you'll do advanced imaging, and the advanced imaging is not done very early, but these imaging are done later on if there's some confusion about mimics. The MR certainly is very helpful for diffusion imaging, but you'd only do this after you've made sure the patient's been worked up for thrombolysis. So remember, this part has to be done rapidly. Our fellows literally see the patient as they're being taken off the ambulance and as they're going for the CT imaging, the CT scanners in the emergency department. So those few minutes is where they'll have the exam and the blood is taken in these patients. Now, my colleague, Dr. Al-Arabi, has already talked about it, but I'm just going to say a few words about what's the tempo of or the speed with which we do these investigations. I completely agree with him that in those patients who come in under 4 hours, all you need to do is to do a CT scan, rule out a hemorrhage, and start IV TPA if they're candidates. Most of this in our patients is done in the CT scanner. If they're under 4.5 hours, we always do a CT angio to look for arterial occlusion and to see whether these patients are candidates for thrombectomy or not. But we don't wait for that. So as soon as the plain CT scan is done, the IV TPA infusion is running. If the patient has a stroke which is more than 4.5 duration, we go into CT perfusion, and I'll give you examples of that. So here's our emergency department. Here's our scanner. We will examine them, make sure that their CT scan looks healthy. We always keep track of our total needle times. So this currently is sitting at 39 minutes. Our most recent ones available are from July of this year. So keep track of how fast you treat these patients. So that is the basic imaging in any patient who's a candidate for thrombolysis. Now the interesting part. The interesting part, because this is what I like doing, and we like treating our patients as early as possible, which is the golden hour. Now, if you're going to treat them in the golden hour, you must buy a CT scanner, which is in an ambulance. But it's so exciting. So here's our CT scanner. Here's a roadside. That's me, incidentally. And as soon as the other ambulance comes in, they'll come in from the front or the back. We put the patient into the back of the ambulance. This is the back in here. Here's our CT scanner. If it's not me, it's usually our stroke fellow. So I'll be in the ambulance a third of the time. Why is that important? The timing is important because the earlier you treat, the better it is. So if you look at the standard of care, excuse me, and if you're asked how frequently does the patient get to your CT scanner in the emergency within 1 hour, and how do you compare that to your ambulance? The Germans a few years ago had done this study from Berlin, where what they were doing in their ambulance, so it's not our data, it's their data. 1 week, they'll use the ambulance and monitor their onset to treatment time. And the other week, it'll be the usual care. So I'm going to show you their data in the next 2 slides. So here, if you look at their time from onset for the first 3 hours. So here's 3 hours. And these are the percentage of patients presenting. So you can see that in the first 60 minutes, there's hardly any patients. None of them present to their hospital for treatment within the first 1 hour. Now compare that to the patients where the stroke ambulance is used. See that? In here, almost 33% of patients are presenting within the first or the golden hour. So why is this important? And why am I spending some time in here? If you treat these patients, you've done a plain CT scan, there's no hemorrhage, there's no other surprises, you think it's an ischemic stroke, and you treat them with IV TPA. I'm going to, in the next 4 slides, show you the comparators, and I made it very simple for you. So treatment, let us say that you had 100 patients in whom you had no treatment. And you were asked the question, how many of them would make a full recovery? So that's the question. You have 100 patients who came in with an acute stroke in whom you did not offer TPA at 90 days, 26% of them will make a full recovery. So this number is really important. Remember that. The natural history of an acute stroke is that 26% of them recover without any treatment. If you treat them within 4.5 hours, which is the standard of care, this number from 26 will increase to 33. So you've got 7 more people who made a full recovery, right? Instead of 4.5 hours, if your system was very good and you treated these patients within 1.5 hours, then you can see that nearly half of these patients would make a full recovery. That's 22% more than the standard of without any TPA. So you can see there's a significant improvement as you treat them earlier. What about 1 hour? Right? That's what I've been talking about as a golden hour. If you treat them within 1 hour, additional 20%. So basically, 70%, almost 70% of patients make a full recovery if you treat them early. That is why, my friends, that is why I am so interested in acute stroke in the first 1 hour, and we go out at any time. And last time I checked, the price of oil was rising. So I hope you can do those kind of treatments in Saudi also. All right, back to my presentation. What about 2 to 4.5 hours? So in these patients that come in, which is the standard of care in most hospitals, our protocol is the following. I showed you this before. Here's our plain CT scan. We would do CT and CTA as Dr. Naif had mentioned earlier. So TPA gets in, here's our TPA running after a plain CT scan. And as the TPA is running, we do a CTA looking at if there's an occlusion and also if there's anything proximal which may impede the catheter going in. Once that's done, I've put the CT perfusion in red because many times under 4.5 hours we'll do CTP also. But in some cases, we'll just take them right after CTA into the angio suite. The time on the table is usually 10 minutes. I will not spend too much time on collaterals. This is an area of interest of mine, and we've done a lot of work on this. But it's really important to look at your collaterals. This patient is not going to do well if you take them to the angio suite, even if you take them within an hour or so, because this person has no collaterals. On the other hand, this patient has an occlusion in MCA. You can see that there are some collaterals, and these collaterals are half decent. But the last example in here is the collaterals go almost as far back as the occlusion itself. This patient has good collaterals. So the clinical outcome in these 3 patients, this is our data. If you don't do anything, you don't give them TPA, don't do a thrombectomy, this is the difference. Bad collaterals, big stroke. Moderate collaterals, small stroke. Excellent collaterals, a tiny stroke. This is good stuff, but you need a radiologist or a trained neurologist who can give you this. And frequently we disagree amongst ourselves. We talk, well, this looks like good to me, and the other person would say, no, I don't think it's that good. So that's where the softwares have come, looking at perfusion imaging, and there are quite a few of those. We were using MyStar. It's from Australia. It's not FDA approved right now. The Siemens have their own software that comes in with your CT scanner. The one that we use mostly currently is called Rapid. It actually shows up on my wristwatch also from outside I can see. And this is important because it tells you the core. The core is 26. And it also gives you the penumbra or the tissue at risk. In this patient, the mismatch is very high. And I'll go back to this again because most of us feel that these kind of software is the future. So the smaller the core, the larger the penumbra, the better that you can expect as a good outcome. And this is another program that you can also see on your cell phone called OLIA. So I'm going to give you an example, actually two examples of patients where I'll show you how important Rapid software is in helping us treat our patients. So example one in here, the 57-year-old young man with severe stroke comes in within 2 hours of onset of treatment. The CT scan looks pretty good. This is an artifact because this patient on the software, so this is what my watch would show, that there is a right proximal MCA occlusion. Then what you can do is, then you can actually, as Dr. Naif was showing, you can actually look at thick images on that software to see what your collaterals look like. So here's an example, same patient. Here's the occlusion and collaterals look okay. But I'm always leery of this. I mean, are they okay? And what does that okay really mean? So in this patient, we have an occlusion. We've got some degree of collaterals. That's the penumbra in green, but even at 2 hours, this patient is showing signs of early ischemic changes. So this is where what I find this software very interesting is that it gives you what's called the hypoperfusion index that shows to you the area which is where the blood is really slow, we call it Tmax more than 10. This area is going to rapidly go into irreversible injury. So not only does this information, the software gives you where the occlusion is, what your collaterals are looking like, what your mismatch is, it also talks about this green tissue and gives you the speed. So the higher the hypoperfusion index, the faster this tissue is going to burn out. We treated this patient with TPA because they were in the window and also had an EVT, but the results were not that good. Compare this to a second patient. It's right here. So this patient is 78 years old. He presented 14 hours into a stroke with aphasia and hemiplegia. You can see that there's a big penumbra, the green stuff, and hardly any core. The core is only 4 mils, and the penumbra is more than 125. So big difference. In this patient, compared to the previous one, you can see that the hypoperfusion index now is 0.1. So this tissue, which is the penumbra, is actually very slowly going to go into irreversible injury. So this patient was outside the window for TPA, went in for a thrombectomy, the occlusions out there, good collaterals, gets first pass, the vessel opens up, and you can see 24 hours later, the flare does not show any evidence of an ischemic stroke, and the patient made a nearly full recovery. So imaging is very important for you, and imaging helps you determine patients where you can expect a good recovery versus a bad recovery. I'm going to give you 2 more slides, 2 more examples before I go to the next part of my presentation. So this is Dr. Naif talked about the study ESCAPE. We were the primary sites in Alberta running the trial. Here's an example. We were using MyStar in those days. Of a 71-year-old who's in hospital for 5.5 hours. So this patient's plain CT scan looks good in aspects of 9, the occlusion of M1, and excellent collaterals. And the perfusion imaging shows large core, scattered, large penumbra, little cores. This patient gets randomized to thrombectomy. 24 hours later, you can see there's very little infarct. The patient does well. This is our other patient, again randomized in within less than 2 hours, where you can see that there's hardly any collateral. See, these are the blood vessels on the normal side. There's hardly any collaterals, and you can see that even at 1.5 hours, the core is so large in this patient. He's treated within 3 hours, 20 minutes from onset. And unfortunately, despite opening the vessel up, you see a large stroke with the hemorrhagic transformation in this patient. So to summarize for you, imaging of good quality CT scan is sufficient to start your TPA within less than 24 hours. You need CT angio for a thrombectomy. And if your patient is beyond 4.5 hours, your perfusion imaging can be very useful to find out if the patient is progressing slowly or they're progressing fast, as I've just explained to you. I have one other issue that I want to quickly touch base on, which is should we be using IV TPA or should we be using tenecteplase, right? As of today, in August, most of us use alteplase instead of TNK. And there is good likelihood that within a year, probably with less than a year, we may be switching to TNK because most data, here is a meta-analysis, a recent meta-analysis in stroke from 2 years ago, everything would indicate that if you compare TNK to TPA in randomized trials, about 5 trials, with half the patients, 800 treated with TNK and about the same numbers treated with alteplase, that there is every evidence to suggest that the risk of complications and the risk of good outcomes is fairly similar between TNK and TPA. But we need some more data. So in Alberta, we are running a trial called Acute. It's about 1,200 patients now. We need another 400 or 500 patients. And hopefully we'll have the answer by this time next year. So then my next part is what about up to 24 hours? So most of this is with thrombectomy, with the diffuse and Dawn trials. And I'm not going to talk about that because there is a presentation by my colleague who will be talking about thrombectomy. What I want to talk about, though, is the wake-up strokes. And in wake-up strokes, how do you investigate them and find out if they are candidates for IV TPA or not? Here is an example. This person's 82-year-old, well-controlled hypertension. That is an A, gaze deviation, has hemiplegia, and an NIH SS score of 14. So this could be right side or left side. They come into our emergency department because they were last seen well the night before. In these patients, imaging is everything. If the imaging shows you something like this, large core, I beg your pardon, large penumbra, no core, large area at risk, but no damage, these patients be taken for IV TPA, and if the IV TPA is not working, we take them for thrombectomies. These are the difficult ones. You know, you have a small core, but small penumbra also. We would err on the side of giving them TPA, but most of them have distal M1 or an M2 occlusion. For this patient, very large core, although there's a large penumbra, these patients, we would not give TPA when they come up in the morning. What is the data? Published data? The published data is a study called, there's two sets of data. This is a wake-up stroke, which was using MR, diffusion flare mismatch. And most of the patients were with mild strokes, and 90% of them were wake-up strokes. And they showed that if you treat these patients with TPA, compared to placebo, you can see an almost 12% absolute difference in outcomes. Now, most of you, like my center, don't have an MR available in the emergency department. So the question has always been, what if you do the type of imaging I showed you, this kind of imaging, perfusion imaging on CT scan? There's some data for that. And there's a meta-analysis, and I'll just share those with you before I conclude my presentation. So this I've shown you. So here is association between reperfusion after thrombolysis in the 4.5 to 9 hours or wake-up strokes that uses CT perfusion. And the data is pretty impressive. Overall, reperfusion was associated with improvement. The odds ratio are very impressive, 7.5. And reperfusion was equally effective in the 4.5 to 6 hours, 6 hours to 9 hours, and in over 9 hours. So compared to placebo, patients who get TPA using CT perfusion gives you good outcomes. Here's an example. So if you're looking at functional improvement of at least 1 on modified Rankin scale, those who get perfusion, you can see that's very impressive. If you look at functional improvement of patients who actually go go home, they also are much better off if you give them IVTPA based on perfusion imaging. Excellent outcome. Again, those who got TPA are much better, and patients who show early improvement within the first 24 to 48 hours, those who got TPA are much better than those who did not, right? The final part of my presentation then is on what about beyond 24 hours? Now, this is for mostly comprehensive care centers. There are a few patients that you don't want to miss. And these patients you would see, especially with, you'd only see them if you do perfusion imaging, whether it's MR or CT. So the data is here. This was published a year ago in JAMA from Korea. They did 150 patients. And those who had small core, large penumbra, even after 24 hours, you can see that best medical management is here, which is roughly about 36% of patients made a good recovery, compared to those who got endovascular treatment at 36 hours, 48 hours, up to 7 or 8 days. If you open the vessel up, that nearly 55% of the patients made a good recovery. So, you can go out to several days as long as you can show that there's a big mismatch. So I'm going to end my presentation with the following messages. First of all, I'll show you the data from Qatar. Before we got there, you can see the number of patients who are getting TPA. So it's up to here. This is the number of patients who are getting TPA. As soon as you created an acute stroke comprehensive program, the number started increasing. So you have a good program, you'll get many more patients who are improved with your treatment. The program is essential. That should include pre-hospital notifications from the ER, from the ambulance to the ER, your ER and stroke unit I've already described to you, and you've got to treat these patients fast. So as the number of patients were increasing, we were also showing that your door to needle time was decreasing. See, the door to needle time in here is average of about of less than 40 minutes. So big dividends if you work hard. What are my conclusions? I have the following conclusions for you. Stroke diagnosis and prevention of complications requires a comprehensive, multidisciplinary approach. This is absolutely essential. If you want to be a stroke program, and I know that in Jeddah, and maybe in Medina, the Saudi German hospitals are designated stroke programs. So these are important. You need to have a comprehensive, multidisciplinary approach. I hope I've convinced you that stroke patients are best managed in stroke units, and they must leave the emergency department as soon as possible. Emergency department is no place to treat acute stroke. Really, really important. I've also, I hope, convinced you that for thrombolysis to be effective, it must be given as early as possible when a patient comes to the emergency department, or if you have a stroke ambulance. So if somebody's had a stroke, an hour ago, and they come to your emergency department, you don't have 4.5 hours. The sooner you treat them, the better your outcome would be. Finally, in patients where their stroke, especially if it's beyond 4.5 hours, multimodal imaging, and I've shown you lots of examples of CT perfusion using the rapid software. Multimodal imaging is very important in correctly identifying the patients who would make a very good recovery. So I stop here and I'll open it up for questions. And thank you for your attention.
Thank you very much, Professor Shuaib, for this comprehensive lecture. You give us idea how to supply the patient, importance of the stroke ward and the stroke unit, and the rapid treatment of the patient with a stroke regarding thrombolysis and thrombectomy. It is very comprehensive, actually, the lecture, and you cover all the topics. I want to inform also you that in our Surgeon Hospital Jeddah, also we have a stroke unit, and it is we have a primary we have a GCI accreditation for it as a primary stroke center, but we are capable also of doing a thrombectomy. Also, we are doing a thrombectomy in our hospital, Jeddah, Surgeon Hospital Jeddah.
I'm very impressed. I know about your program, Dr. Mustafa. It is great that you can work across many hospitals and get your patients in fast. My congratulations to you and your colleagues.
Thank you, sir. I have a question. What is the prognosis of treatment the patient with thrombectomy after from 16 to 24 hours? What I will tell the patient, what is the percentage of complication like hemorrhage, like hyperperfusion?
That is an excellent question. So I did not show you a slide, but if you, so we had in Escape, we had gone up to 12 hours. In Diffuse, it was 16 hours, and Dawn was 24 hours. Because your treatment is based not on time as much as what you see in your imaging. So let us take an example of somebody who comes in at 23 hours or 25 hours, and their core is small. It has to be under 70 mils, and your penumbra is large, right? So large penumbra, small core, many hours after the onset. You have a thrombectomy that's successful. There is no difference in that patient's outcome compared to somebody where you do it at under 5 hours. So the number needed to treat for a full recovery in Dawn and Diffuse were 1 in 3. So in 1 in 3 people would make a full recovery. So time becomes almost irrelevant when you're actually using imaging for your selection.
And what about the bridging therapy? If I can do thrombectomy for the patient immediately before going back to the emergency room or start the TBA, it's better to do the thrombectomy alone, or I have to give also the TBA during the thrombectomy procedure?
Yeah, that's another very good question. And as you know, there's been a lot of publications on the subject right now. From Japan and from China, there is randomized trial data that TPA does not add. So if you're going to go to do a thrombectomy, the TPA would not improve your outcome. That's the randomized trial data from the Far East. Practically speaking, and I'm sure your colleagues would agree, approximately 10 to 15% of patients who get TPA, and about double the number of patients, about 20% of patients who get TNK, during the time the drug is infusing and until you get to the angio suite and start working, these arteries open up because of your thrombolysis. So our strategy has always been that if they're under 4.5 hours, we give them TPA. We actually give more than half of them TNK right now. And if it's between 4.5 hours and 24 hours, we have a clinical trial running where we compare TNK to placebo. So under 4.5 hours, we will always give them a thrombolytic as they're going for their thrombectomy. And there are many reasons for that. As your colleagues will tell you, sometimes you don't have access. You may have a carotid occlusion, or they may have really bad femoral or iliac arteries or aorta. So giving TPA is in general a good idea if you're treating them under 4.5 hours.
Okay, thank you, Professor. Any question, please, for Professor Sharif? Please, if you have any question, you can type it in the Q&A. So for the time being, there is no question for Professor. We are going now to, okay, thank you very much. We are going now for the third speaker, our Dr. Muhammad Al-Wadi. He's a stroke neurologist and a neurointerventionist at King Fahd General Hospital, Jeddah. He will speak about mechanical thrombectomy in acute ischemic stroke. Okay, Dr. Muhammad, we are ready to hear from you.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. First of all, I would like to thank the organizing committee in Saudi German Hospital for inviting me to give this talk. It's been very, very good to join big figures in the fields like Prof. Shuaib and Prof. Meeting. My talk today will be about the mechanical thrombectomy and acute stroke.
Dr. Al-Wadi, on the right-hand side down, there's an option to...
Yeah, I think it's good now.
Yes, perfect.
I have no disclosure. My objective in this talk will be about the concept of mechanical thrombectomy and an acute stroke, background, evidence, patient selection, then recent guidelines and technical aspects, then factors affecting the outcome of endovascular treatment, then finally some recommendation. The concept of endovascular treatment, it's mainly regarding the recanalization. So the recanalization of occluded vessel improve the clinical outcome in acute ischemic stroke, which lead to reperfusion and salvage of threatened tissue. So the important factors correlate the recanalization to outcomes: time, and again time, and again time, followed by collaterals and reperfusion injury. As you can see in this paper from 2007, that ischemic penumbra can be salvaged if vessels rapidly recanalized. And this meta-analysis showed strong correlation between the recanalization and the good outcome. So if we see the functional independence, which is MR is 0 to 2 in recanalized patient is close to 60%, while it's around 25 in non-recanalized one. While the mortality increased significantly in those patients who has no recanalization of the vessels. And the symptomatic hemorrhage is almost similar in both groups. So the successful recanalization is associated with 4 to 5-fold increase in the odds of good functional outcome, and also 4 to 5-fold increase in the odds of mortality. Why the time is brain, why the time is so important in acute stroke? As from this paper from Safer in 2006 and his colleague showed that with each minute with large vessel occlusion, the brain will lose almost 2 million neuronal cells, and per hour 120 million. It will lose per minute 14 billion synapses, and accelerated aging is 3 weeks per minute and 3.6 years per hour. So on some background that intravenous recombinant tissue plasminogen is the standard of care for selected patient with acute ischemic stroke presented with 4.5 hours from symptom onset. Only about 25% of ischemic stroke patients present to the hospital within the time window for IVTBA. And here, once we see the large vessel occlusion, it's about 35 to 40% of all acute ischemic cases. It's very severe. It leads to 4.5-fold increase in the mortality and also 3-fold reduction in functional independence at 90 days. They respond poorly to IVTBA. Successful opening of occlusion by intravenous TBA is about 4 to 8 in ICA terminus, and proximal MCA 24 to 32%, while in M2 branches reaching to 31 to 44%. Some background and something to know about the stroke and endovascular treatment. National Institute of Health Stroke Scale, or NIHSS, Alberta Stroke Program, early CT score or aspects, modified Rankin scale, and thrombolysis in cerebral infarction, or TK score or TK scale. So the NIH stroke scale is a systematic assessment tool. It's a predictor of lesion size and measures of severity. It's a predictor of short and long-term outcome. It's designed to be a simple, valid, and reliable tool that can be administered at the bedside consistently by physicians, nurses, or therapists. And it provides a common language for healthcare providers in stroke patients. The total score is from 0 to 42, with higher values representing more severe infarcts. More than 25 points, it's a very severe neurological impairment. 15 to 24, it's a severe impairment, while 5 to 14 is a moderately severe impairment. And less than 5 is a mild impairment, and it depends on which point is lost in the NIH stroke scale. The aspect score, it's a 10-point quantitative topographic CT scan score used in patients with middle cerebral artery stroke. As we can see, it's two-level ganglionic level and supraganglionic level. In the ganglionic level, we have 6 points: caudate and lentiform nucleus, internal capsule, and we have actually 7 points plus insula. Then M1 and M2 and M3 divisions at the level of the basal ganglia. Then above the level of basal ganglia, we have M4, 5, and 6. The modified Rankin scale, it's 0 to 6. 0 is normal, while 6 is dead. The functional independence usually is 0 to 2. In 1, there is some symptoms, but the patient is not disabled, while in MRS2, they cannot do the briefest activity, but still they are independent. At 3, they need some help, but they can walk. So they need some walking aid. While at 4, it's patient who is a wheelchair bound that he cannot walk. And 5 is a nursing home patient or someone who's bed bound. They need 24 hours care. Then the thrombolysis in cerebral infarction or TICI scale. This is the original one which was taken from the TINI from MI and recanalization in myocardial infarction patients. So usually 0 to 1, there is no or minimal reperfusion, while 2A is a partial filling, or let's say this time 50% the modified, and the last one modified TICI with 2C. If we see 2B, that's been a partial filling more than 50% of the territory, while 3 is a complete perfusion. In the last one, or modified TICI with 2C, they added the 2C with, if there is distal small branches that is occluded, but the main branches or most of the branches open. So it's a near complete perfusion except slow flow or a few distal cortical emboli. The history of endovascular stroke therapy actually started very early from 1990s. Initial promising trial was PROACT-2. There was some sort of good outcome, however, the bleeding risk was quite high. Then later on, engineering of the devices, then Mercy introduced in around 2005, then again, Penumbra 2008 to 2009. Swift and Trifo was in 2002. Then many trials was negative in 2013, IMS3 synthesis and expansion. Then after that, a lot of medication, a lot of modification for the endovascular materials, especially the stent retriever and big aspiration catheters, get the result of a big successful endovascular trials. Mr. Clean, Extend IA, Escape, Swift Prime, and Refascat in 2015. Then later on, ASTER trial and Compass comparing aspiration versus stent retriever. Then Dawn and Diffuse in 2018 for the late presenting stroke. The early negative trials in 2013, mainly Mercy, Mr. Rescue, and Synthesis plus IMS3, there was angiographic study which is not from inclusion criteria. So they have some sort of wrong patient selection. Then they used in that time patient design and engineering of the thrombectomy devices, mainly Mercy and early Penumbra devices. Then, however, the subgroup analysis showed benefit signals. Then in 2014 and 15, by end of 2014, the first trial, Mr. Clean, followed by other trials, Escape, Extend IA, Refascat, and Swift Prime, all came positive with statistically significant results, with very good recanalization rate. If we compare these numbers to the early trials in 2013, it was almost comparable to the IPTBA in around 25 to 40%. So the recanalization rate was ranging from 60 to almost 90%. Then if we see the devices they used in these trials, they mostly used a stent retriever exclusively in 3 trials and in about 80 to 85 in other Escape and Mr. Clean. The time window for this trial was the early window, which is 0 to 6 hours. However, some trials up to 12 hours in Escape and Refascat 0 to 8 hours. It was all in anterior circulation, ICA, M1, M2. There was no significant regarding the safety outcome for those for these trials and treatment. It was comparable between the endovascular arm and the control arm. If we see the outcome summary, in these trials, very statistically significant difference in the MRS at 90 days. The number needed to treat to achieve an independent outcome at 90 days and keeping the patient independent after the stroke. In Mr. Clean is 1 in 7, Escape 1 in 4, Extend IA 1 in 3, Swift Prime 1 in 4. Refascat, you have to treat 6 patients to have a good outcome in 1 patient. Then meta-analysis and by Helm's group was done for these 5 trials. which again showed the number needed to treat for one patient to have a reduced disability of at least 1 point in MRS was 2.6. They have very good outcome regarding the intervention arm, 46 compared to 26.5. Regarding the safety outcome, it was comparable regarding the mortality and symptomatic intracranial hemorrhage. Based on these trials, the AHA, an American Stroke Association guidelines, was changed in 2015, modified from 2013. Patient was eligible for IV TBA should receive the TBA even if endovascular treatment are being considered. Then the patient should receive the endovascular therapy with a stent retriever if they meet all the following criteria. They have to have a pre-stroke MRS score 0 to 1, then acute ischemic stroke, receiving IV TBA according to the guidelines from Professional Medical Society. Then it has to be an anterior circulation, mainly the ICA and M1, age more than 18, and NIH stroke scale should be 6 or more, and aspect should be 6 or more. Then treatment can be initiated and the groin puncture within 6 hours of symptom onset. Then after these trials and overwhelming evidence for endovascular treatments, the late presenting stroke trials came out at late 2017, early 2018. The DAWN trial, 0 or 6 to 24 hours. So they randomized those 2 arms, one for thrombectomy with a specific inclusion criteria, and the other one, the control arm, which is a best medical treatment. Then again here, there was a significant shift of MRS 49 compared to 13% in the control arm, with almost comparable symptomatic ICH 6% compared to 3%. And the 90-day mortality was 19% in endovascular arm compared to 18% in the control arm. Then diffuse was stopped due to significant results from the DAWN trial, and analyzed an interim analysis, which again showed almost the same effect, with MRS shift 45% in the EPT group compared to 17% in the medical therapy. And again, the symptomatic ICH was 7% compared to 4%, and the mortality was actually better here in endovascular arm, 13% compared to 23%. The late presenting stroke with large visual occlusion, which may be DAWN and diffuse 3, it's all in anterior circulation, ICA or M1. Then the time was in DAWN trial 6 to 24, while in diffuse 3, 6 to 16. The diffuse 3 was sponsored by the NIH, while the DAWN trial, it's an industrial sponsored trial. However, the results were overwhelming for significant outcome. And if we see the NIH for late presenting stroke, in DAWN, the minimum was 10 point on NIH stroke scale, while in diffuse was 6. The number needed to treat for the mechanical thrombectomy for stroke compared to others is very significant. So as you compare it to defibrillator for ventricular fibrillation, sepsis and AD goal directed treatment, PCI for MI, aspirin for MI, and bariatric surgery. So it's a very significant result. So based on those late trials, again, the guidelines was updated in 2019. Same thing for 0 to 6 hours, they should have the TBA plus mechanical thrombectomy with the previous parameters, MRS 0 to 1, aspect 6, NIH 6 or more, with anterior circulation occlusion. Then 6 to 24, if they met the diffuse or DAWN criteria, they should have the mechanical thrombectomy done. Then what's the difference between the positive and negative trials in endovascular treatment of stroke? So there is a better patient selection based on the brain imaging. angiographic imaging like CTA, MRI, or perfusion, there's a good timing and very fast onset to triaging, to recanalization of the artery. There is a better devices regarding the material used in the procedure, more effective recanalization and faster recanalization. Regarding the endovascular technique for stroke, either balloon guide catheter plus stent retriever, direct aspiration first pass technique, Solumbra, which is an aspiration catheter plus stent retriever without flow arrest, then many other techniques like captive, ART, safe. So it leads to advanced mechanical aspiration technique, which is combined technique using balloon guide plus aspiration plus stent retriever. So the aim or the goal is to have the higher rate of recanalization without increase the risk of complication. So if we can see here in these pictures that the stent retriever, they use the balloon guide catheter, the ICA with flow arrest, the microcatheter deployed to the area of occlusion, like for example, an MCA, putting the stent, then pulling the clot and the stent through the balloon guide catheter. The other technique, which is an adapt technique without flow arrest, having the aspiration catheter against the clot in direct aspiration. The last one is the Solumbra, for example, here using the same thing, aspiration plus stent retriever without flow arrest. So there are many ways to approach an acute stroke mechanical thrombectomy, either intubation versus conscious sedation. So in those patients who's having, for example, basilar occlusion or very irritable with right MCA occlusion, sometimes you need the anesthetist with you. Which sheath you will use? Would you use a long or short sheath? Which size you will use? 6 French, 8 French, 9 French. So it depends on many factors like patient anatomy, availability of the devices, type of technique you will use. Then would you use a no-guided or a guided catheter? You would use regular guiding or balloon guide catheter. Would you use a distal or intermediate catheter or just simple microcatheter plus stent retriever and balloon guide catheter? It depends on the type and size of devices. There are many devices, for example, stent retriever in the field. And also regarding the aspiration, would you use a manual, bump, and which type of aspiration we use? We have almost many catheters now, more than 4 to 5 type of aspiration catheter that can be used, or 5 company who's competing to produce a new generation of aspiration catheter with good outcome. Then pharmacological adjunct TBA and treatment of vasospasm, and the most important thing to do during the procedure is when to stop. You have to know exactly when to stop the procedure. Sometimes, as Dr. Shoaib mentioned or Prof. Shoaib mentioned earlier, there are some difficult access. For example, there are occluded femoral artery, occluded aorta and arch. Sometimes you would have an extracranial severe stenosis, sometimes vessel dissection or vessel occlusion. So keeping the TBA on board in the first 4.5 hours is a really good advice in those type of patients. The APT metrics for better outcome, the time, recanalization rate, which is TK2B/3 or TK2C. The goal is to avoid an embolism to a new territory. And clinical outcome, we are targeting a good functional MRS like 0 to 2 to have the patient independent after the stroke. The number of passes and recanalization percentages are very crucial. This is one patient who was 34 females, last seen was 5 hours from the onset or presentation to the ER. NIH was 15. She has an aspect of 9, the plain CT, and there is an M1 occlusion. This patient underwent an endovascular treatment with Solumbra technique, and there was a full recanalization of the MCA with TK3. And NIH was 0 at 90 days, and this is a follow-up MRI. So there are many factors affecting the EVT outcome. There are some factors related to the patient himself, and some radiological factors, then some system or system-related factors. For example, in patient factors, we know that the very elderly with a lot of comorbidity is really would lead to some sort of increased morbidity and mortality. And stroke severity and high night stroke scale is again something to affect the outcome. And witness onset, and those patients with witness onset who presented very early, they have the best chance to have a good outcome if they have a good recanalization. In some radiological factors, there are some sort of admission neuroimaging depending on the protocol of the hospital, then which is anterior or posterior circulation and the clot burden, collateral circulation, and arterial access. Regarding the system, it depends, is it day or night time, weekday versus weekend, distance from the hospital, and team experience, and access to the Neuroimaging suite. So I would conclude with this slide that the current evidence suggests pulmonary catheter plus stent retriever or ADAPT technique all are acceptable first line of approach for acute ischemic stroke with large vessel occlusion of the anterior cerebral circulation. Systematic standardized approach for EVT will likely decrease the procedural time, increase the recanalization rates, and improve clinical outcome. Regardless of the technique, some clot are resistance. Know when to stop the procedure is very crucial and important. Thank you very much for listening, and open up for any question.
Thank you very much, Dr. Mohammed, for this excellent presentation. I have two questions for you. Is there any difference between different type of stents you are using?
Stent, it depends actually on the sizes. There are many companies. So the most used or most stent used in the beginning was Solitaire, which is from Medtronic, and followed by Trif. But then again, many other stents like Embotrab and Penumbra stent. So it depends on the availability, it depends on the design of the stent, depends on the location of the clot, anatomic or angio architecture of the vessels. So there are many factors to play a role here.
Okay. Another question, what is the prognosis of thrombectomy of the basilar artery occlusion? Even if you have successful recanalization, is the prognosis is good?
We have, there is some controversy regarding the thrombectomy in basal and late trials that came with almost very excellent outcome with medical treatment, actually. While practical aspect or in daily practice, the outcome of basilar occlusion is really bad. So we have very good outcome and many patients being done with basilar occlusion. Bottom line, if the basilar occlusion has no underlying intracranial artery, the outcome is really perfect. While if there is an intracranial atherosclerosis in the either V4 segment of the vertebral artery or in the basilar, usually the outcome in both arms will not be that good.
Another question, are you giving TBA intraarterial if the vessel is not opening and the patient not receive TBA? Are you giving intraarterial TBA?
We usually do that, especially for distal branches that we cannot reach it with a stent or with the aspiration catheter.
But this depends on the time, and it is the evidence before 4.5 hours or even after 4.5 hours.
No, if it's in the window, like for example in the
window
with mismatch or in the first 6 hours.
Our attendees have a lecture, have questions. The first question is asking about what about CME hour. He's asking about the CME hours. Okay, yeah. Mr. Shubit will answer this one. Another question. Okay. Any question for Dr. Mohammed? Okay. We have also Professor Shoaib was asked Dr. And Dr. Naif also was asked any question for our speakers. Okay, Professor Shawab, any comment from your side?
Sorry, what was the question again?
No, I'm asking if you have any comments. Any comments, any instruction you want to give it more?
No, I think I am very impressed with the quality of the two presentations before and after me, and I hope your audience would get the message. The most important one is that, stroke is very treatable, but you have to properly select your patients. That's why imaging is very important. And every piece of evidence coming out shows that, especially when you're doing a thrombectomy, the way the expertise and the experience of the person who's doing it is critical. Also, these literally every week, new tools are coming out that can access clots a little easier. Suction devices are out there. So there is a lot of excitement. And I'd advise you that whenever you see your neurologist or radiologist who do thrombectomy, you should take them out for coffee and tea and, give them a massage. They're working very hard. There's not too many of them around. So they're doing a wonderful job. And I feel these programs that you organize at Saudi German hospitals are extremely useful. I'm always very happy to see the very large participation. I hope the presentations have been useful to your audience. I enjoyed listening to my two colleagues who presented before and after.
Thank you, Professor Shah. There is a few questions. Maybe it will be between you and Dr. Muhammad and Dr. Naif. First question: if we have TBA and tractabilis, which one you like to give?
If the question is to me,
yeah,
I think currently you should follow your guidelines. And so if your guidelines indicate that you use TPA, then you should use TPA. Tenecteplase will probably, in 1 year's time, I'm just reviewing another protocol. Just when I was listening, someone sent it to me from Australia. They're actually starting another trial in Australia looking at TNK versus TPA. Our trial is almost complete. I think there's convenience and it's easy to give. It's just one single shot. It's more specific to the clot. Duration of action is longer. There's good reasons to expect in the future that TNK would be your drug of choice. But currently, I would strongly suggest that treat patients. So if you have an eligible patient, whether it's 2 a.m. or at odd hours, you should always treat them. And TPA is as good, and you have more experience with TPA. So my preference would be TPA for now.
Another question for Professor Shoaib. What are the importance of giving statin to stroke patient?
Can you repeat the question again? What are the
importance of giving statin to stroke patient?
Oh, that's a very good question. It's an excellent question. So it's prevention, right? So basically, there is a lot of it's very strong data that the lower your LDL cholesterol, the better your reduction in recurrent stroke. And it's not just recurrent stroke. It's good for your heart, it's good for your kidneys, it's good for your peripheral arterial disease also. So we always give the maximum dose that the patient can tolerate. So I would start with 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. Remember, in the Western countries where these numbers come from, statins and metabolic syndrome or high triglycerides are not as important as they are in the Middle East or the southeast or far east. So statins are extremely important. Every single patient from our hospital who's discharged is on a statin, unless, of course, they can't tolerate it. Excellent question.
Thank you very much. There is another question regarding the indication of thrombectomy for posterior cerebral artery thrombus.
I'm hoping Dr. Yasir or
Is there any indication for thrombectomy for posterior cerebral artery thrombus?
Oh, I think it is, of course. Anytime somebody has a thrombus in the posterior cerebral artery and their brain looks good, we always treat them, even if it's the second level. So it doesn't have to be proximal; it could be somewhat distal also. But we have a very good presentation from our colleague who just presented. Is it? I think Dr. Mustafa could answer that better.
Dr. Naif is still with us.
Oh, okay. Excellent.
Thank you very much. Dr. Naif, there is another question. What is the possibility of clot to be fragmented or while doing the endovascular procedure? Okay. Professor, are with us? Dr. Shaib?
Yes.
This question asking about the possibility of clot to be fragmented.
Oh, we don't worry about that. Yeah, we don't worry about that. Basically, what you do is there's always going to be a small, tiny fragments that will go distally. So if you do an MRI the next day, you see small hits. But that's not an issue at all. With these suction devices that our colleagues use, it's pretty good. I would actually not worry about fragmentation. The most important thing is opening an artery. So that's not an issue at all.
Okay. Thank you, Professor, for being with us today. We needed to ask a lot of things. And I also like to thank Dr. Naif Harabi and Dr. Muhammad Al-Wadi for their excellent presentation. And it's nice, inshallah, to meet you again and again in the future. I hope it will be also not virtual, it is physical. Inshallah, after this pandemic and the mass vaccination we are having. And I would like to thank our organizing committee, Dr. Yasser, Mr. Shobit, Mr. Saleh, and the smart William. Thank you, everybody. And I wish you a safe life, inshallah. And assalamu alaikum wa rahmatullah.
Wa alaikum assalam. Inshallah, see you in person.
Thank you so much.
Thank you. Thank you.